Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. And what are some CTP clinical pitfalls and limitations? The first to consider is stroke mimics. What are some technical CTP pitfalls? Well, the patient may move. The brain coverage is provided with a single CTP slab or a single look. We know that the contrast bolus timing and the CTP timing can vary. And with a large vessel occlusion, contrast arrival may be slowed, and the CTP scan may end before all of the contrast has moved through all of the brain tissue. We know there can be an insufficient bolus due to IV access problems or low cardiac output, which will push blood and the contrast to the brain in a delayed manner, and there are issues related to radiation exposure. What about the CTP core infarct calculations? What are some pitfalls there? We know that the traditional core infarct calculation is based on a CBF less than 30% of normal, and we know this assessment can both under or overestimate the size of the core infarct volume. And it's important then to use the aspect score to determine if a large hypodensity, which denotes the likely infarct size, is related to an acute stroke. So it's better to screen to offer EVT more often. In other words, if the CTP appears to be limiting the number of patients that are going for EVT therapy, it may be optimal simply to do anatomical vessel viewing with a CTA and an MRA as opposed to waiting and or utilizing CTP, especially if your own AI software decreases the number of patients who apparently go to or would benefit from EVT therapy because of the presence of a likely large ischemic penumbra. And what about the ischemic penumbra calculations with CTP? So there can be an overcall of penumbra commonly in the skull base, in the posterior fossa, and or in areas surrounding the orbits. We know that with limited arterial flow due to carotid stenosis or low cardiac output or AFib, there may be some errors in the calculation of the ischemic penumbra. And in those cases, it is possible to do manual CTP penumbra volume adjustments or calculations. However, this can take time and delay decision making regarding delayed thrombolytic therapy and or EVT. And what about CTP and stroke mimics? We know that seizures, hypertensive encephalopathy, hemiplegic migraines, and the Press syndrome all can cause vascular dysregulation. And we know that variants can also cause there to be changes in CT perfusion assessments. We know that hypoperfusion can be suggested or overcalled incorrectly, and you have to correlate your CTP with clinical symptoms and your vascular finding on CTA. What about posterior circulation and lacunar infarcts? We know that the benchmarks for the algorithms for understanding CTP in posterior circulation stroke are less clear. We also know that CTP is low sensitivity for lacunar infarcts, especially in the basal ganglia and thalamus. And we know that MR-DWI may be superior diagnostic modality for the posterior circulations, lacunes, and watershed infarcts. So in summary, in posterior circulation problems, if you're trying to accurately assess the size of the core infarct and the ischemic penumbra, MR-DWI testing may be a superior choice. So how do CTP and MRP compare clinically? Compared with CTP, MR perfusion is inherently less quantitative because the signal is not proportional to the concentration of contrast. In other words, there's no gadolinium contrast bolus that would allow you to come up with a numeric quantitation of the size of these infarcts and ischemic penumbra areas. And we know that MRP requires the use of echoplanar imaging, and they can have multiple artifacts with the use of this because of any blurring or misregistration or signal dropout, especially near the skull base. One last consideration, non-contrast CT versus CTP for EVT referral. What are we talking about here? In patients who are evaluated in centers that do not have CT perfusion, can you refer patients for EVT accurately and send them to a comprehensive stroke center just from the use of non-contrast CT? So, is CTP causing referral for EVT to become too restrictive? And should we use just an NCCT in order to evaluate for the need for EVT? We know that if a large core infarct is seen on CT perfusion, the patient is less likely to get EVT. And although this is likely the right way to approach patient treatment, it may be that we are restricting the number of patients who should go for EV therapy. And a large systematic review listed here does suggest that a non-contrast CT may perform equally well to CT perfusion in the optimal referral for EV therapies. And in fact, the 3-month functional outcomes and symptomatic intracerebral hemorrhage rates were comparable in patients who received EVT based on selection with simply a non-contrast CT or CT perfusion. So is it possible that the use of late EVT can be successfully determined with a non-contrast CT for those of you who work in centers where CT perfusion is not possible? So again, from a study listed here, the 3-month functional outcome and symptomatic intracerebral hemorrhage rates were comparable after EV selection based on either the non-contrast CT or CT perfusion. It looked at 5 studies, almost 4,000 patients, and it looked at the late EVT window of 6 to 24 hours. And in fact, the CTP image did have higher reperfusion likely and a lower mortality. Odds ratios listed here. What this states or suggests is that if you do use CT perfusion, you are more likely to have higher reperfusion and lower mortality when referring for EVT. However, it is still possible to refer for EVT using a non-contrast CT alone if you do not have CT perfusion available in your center. And remember, from this systematic review, these studies were not randomized, and it is possible that there is some bias. That is, it may be that there's higher rates of reperfusion and lower mortality related to CTP because this test was provided or given to patients who were more likely to optimally benefit or receive EVT therapy. So, is non-contrast CT or CTP superior for EVT triage? Well, again, we have a concern that CTP will restrict the amount of EV therapies if a large core infarct is seen. We know that functional outcomes and symptomatic intracerebral rates are similar whether you use a non-contrast CT or CT perfusion. And we know that CT perfusion does provide more reperfusion therapies and lower mortality. What's the summary? Use CT perfusion when it's available and feasible and clinically relevant. Otherwise, you can identify large vessel occlusions using non-contrast CT, the NIH stroke scale being higher than 9, for example, as a marker of a more severe stroke and a more likely large vessel occlusion. And you can use the VAN assessment, where patients who demonstrate both unilateral weakness and the presence of visual aphasia or neglect changes, and use this as your notion for referral for EVT. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.